Regali. I am a consultant nephrologist in Brighton, and I am a senior clinical lecturer at the PSMS. So, the kidney. As you know, we have two kidneys, okay? They are retroperitoneal. Each kidney is about 150 grams. And despite of their small size, they play a vital role in our body homeostasis. And as you can see, if we look at the kidney, if we take a cut section, longitudinal cut section, you will find that there is something outside called the cortex, which contains about 85% of the glomeruli. They are cortical nephrons.
Sorry to interrupt. The slide hasn't moved.
Sorry?
The slide hasn't moved. Sorry to interrupt.
Yeah, I'm still. Is it the slide of the anatomy or
still the first slide? Renal failure.
Oh, sorry.
Thank you.
Again. Yeah. Okay. So let me put it in display mode. Okay, can you see the anatomy now?
Yes, thank you.
Okay, so we have two kidneys. Each kidney is connected to a ureter and the bladder, as you know. And each kidney takes a supply from one renal artery and drain into one renal vein into inferior vena cava. And the longitudinal section shows the cortex, which contains the main nephrons. And actually, when you look at ultrasound, if the ultrasound describes to you cortical thinning or cortical atrophy, this means loss of the function of this kidney. I changed the slide. Can you see the next one?
No.
Okay, so.
Oh, yes, now we can.
Yeah, you can see it now. So we'll not be able to play the display mode. And so each kidney, as I said, has about 1.2 million nephrons. And this is a depiction of the shape of the nephron. It is like a blind tube invaginated at the end by afferent arteriole and tuft of capillaries. This makes certain pressure inside the glomerulus to filter the blood and form the urine. And then the urine passes into many processes through the proximal convoluted tubule, lobe of Henle, distal tubule, and then finally to the collecting tubules to form the urine. So what are the functions of the kidney? Okay, so the functions of the kidney, as you know, we have many things. So the kidney first is responsible for elimination of metabolic toxins and water through the urine. So if we lose the kidney function, this can lead to water intoxication, which means severe fluid overload. We can have accumulation of waste products inside the body, high urea, high creatinine, and other waste products, of course. It is responsible for regulating the acid-base balance. Okay, so usually, you know, in renal failure, we get metabolic acidosis because of the loss of the kidney function. Also, it's responsible for the renin-angiotensin system, which is responsible for regulation of blood pressure, release of erythropoietin, so formation of erythrocytes, and activation of vitamin D, which means responsibility for mineral stasis like calcium, phosphorus, and the parathyroid, which we call mineral bone disease. So what happens if both kidneys suddenly fails? So all this will stop. The regulation of water, regulation of waste products, acid base, electrolytes, and erythropoiesis. So let's go to the first scenario. Mr. Jones, he is a 74-year-old man who is referred urgently by his GP, who saw him this morning and did some blood tests. The results of these tests have been called through the GP surgery and show sodium 145 millimole per liter, potassium 6.9 millimole per liter, urea 29.3 millimole per liter, and the creatinine 686 micromole per liter. Okay, so they are the lab findings. Of course, the GB sent him straight away to you hospital, and the GB letter tells you that Mr. Jones has had benign prostatic hypertrophy previously, but is otherwise usually very fit and complaining. He attended the surgery because he had been feeling lethargic and under the weather for the past week, but no other symptoms. Given the blood results, Mr. Jones is called by his GB and asked urgently to attend the medical admission unit. He arrives at 5 p.m. and his initial observations are unremarkable. Okay, so my first question to you: what is your first concern on being asked by the nursing staff to see him? Mhm. What is your first concern about this patient? Do you like to see the results again?
High potassium.
High potassium, excellent. His potassium is 6.9. This is actually very, very important. So he has very high potassium, 6.9. So the main concern, does he have ECG changes associated with hyperkalemia or not? Because if he has ECG changes, this patient can go into arrest soon. So if he does have hyperkalemia, he is at risk of having arrhythmia and cardiac arrest, as you know. Excellent. So the morning bloods done at the GB surgery show significant hyperkalemia. Don't forget that the patient arrived to the hospital 5 o'clock and the blood was done in the morning. So there is a gap. And in this gap, the potassium may be now higher than the morning. So we have some possibilities actually. This result may be spurious due to hemolysis, due to hemolyzed sample, in which there has been a delay in the processing from the GP when he sent it to the lab, hospital lab. However, this degree of hyperkalemia could be life-threatening, so it should be considered genuine result until proven otherwise. So don't say it has come from the GP office and hemolysis may cause hyperkalemia like this. Consider it as the genuine and as this is the real potassium until you get another blood test. So you should deal with the patient as hyperkalemic. Hyperkalemia can actually impose acute and chronic renal failure and should be treated as a matter of urgency, as you know, to avoid cardiac arrest. Okay? So if we ask ourselves, what are the commonest or the acute life-threatening complications of EKI? So we have 3 life-threatening complications of the acute kidney injury. One related to fluid, one related to potassium, the third related to hydrogen ion or acid. So fluid overload, because you know fluid overload can induce pulmonary edema, can kill the patient. Hyperkalemia can induce cardiac arrest, and acidosis also can be lethal and lead to death. So we have 3 fatal complications in acute kidney injury or chronic renal failure. They can endanger the life of the patient. So what are the hyperkalemia symptoms? Actually, it is mainly weakness, lethargy, muscle cramps, paresthesias, and dysrhythmias. Okay. As you know, when the hyperkalemia happens, it will lead to persistent depolarization and makes the cell membrane refractory to stimulation. So this may cause weakness and in the skeletal muscles and cardiac arrest in the cardiac muscle. So we will ask, of course, in this patient for an urgent ECG. So we have some changes usually happens in the ECG. The first one, if you look at the T wave, you find tall and peaked T wave, which we call it camel hump. Okay. Also, you find the prolonged BR interval. You find wide QRS complex, and later on the P wave disappears completely, and then the line may turn flat with cardiac arrest. So it is like, actually, if you are stretching, if you imagine that you are stretching the ECG from sides and from the T wave. So stretch the T wave up, it will be tall and peaked T wave. Stretch the ECG from both sides, you will find, yes, PR will be prolonged, QRS will be wide, and then later on cardiac arrest can happen. If we look at this ECG, you will find the peaked tall T wave. It is very clear. And if we look at the following one, you will find the disappearance of the P wave and the wide QRS. So potassium is dangerous, okay, can cause cardiac arrest. So in view of the risk of cardiac arrhythmias associated with hyperkalemia, what is the immediate measures which you would undertake? First, establish intravenous access and move the patient to a monitored bed. And urgent repeat potassium, you can get it through the arterial blood gas or venous gas as well. Okay, because you know the venous gas assessing the metabolic situation, and perform a 12 lead ECG. And if the ECG has significant hyperkalemia associated changes, you should treat straight away as a matter of emergency, even before waiting for another potassium level. Okay. As you know, the treatment will entail 10 ml of 10% calcium gluconate. And what is the effect of the calcium gluconate here? What is the effect on the level of potassium? Does it decrease significantly the level of potassium?
It just stabilizes the cardiac membrane, but it doesn't change the potassium levels.
Excellent. Yes, it doesn't change the potassium level. It's only just stabilizes the myocardium and makes it refractory to arrhythmia, which helps as cardioprotectant. Okay, so but it has no effect. So don't say I have given calcium gluconate to the patient and the potassium level is as it is, or it's increasing. Yes, it will not affect the level. Okay, and then we give the 50% dextrose plus actrapid. What is the mechanism of insulin dextrose? How insulin dextrose decreases the level?
It drives potassium into the cells.
Good, excellent. Why? So why does it push the potassium inside the cell? Anybody knows? So what will the insulin push inside the cell usually?
Does the potassium follow glucose?
Yes, excellent. Yes, it will push the glucose inside the cell. And remember this, potassium and the glucose are friends, so they will move together. So when you move the glucose inside, you will move the potassium inside as well. Okay, so we add glucose because to avoid hypoglycemia, actually, because if you don't give glucose with the insulin, okay, the insulin will push your body glucose inside and you will push the body potassium inside, but this can induce hypoglycemia. So you are trying to protect against, so you give more glucose beside the insulin to avoid hypoglycemia. But the mechanism here is that the potassium and the glucose, they move together, okay, to the cell, So the insulin will push the glucose inside, and then the potassium follows. Okay. And then consider salbutamol nebulizers. Okay. What is the mechanism of salbutamol? Generally, what does the salbutamol do in general? It is agonist for which receptor?
It's a beta agonist.
Yes, beta 2 agonist, and this is the mechanism we use it for in cases of bronchial asthma. And also, beta 2 receptor, when you stimulate it, it will take the insulin, the potassium inside the cell. So it is the same mechanism like insulin dextrose. The salbutamol also pushes the potassium to inside the cell. Okay, so as you can see, the main things which we do are giving salbutamol and dextrose insulin and also calcium gluconate, but the three altogether, they don't reduce the total level of potassium inside the body. Am I correct? Yes, because salbutamol pushes the potassium inside the cell, dextrose and the insulin pushes the potassium inside the cell. So the total body potassium remains the same, but you are just moving the potassium between compartments. And we said that calcium gluconate will not decrease the level of potassium. And this is very important. Why it's very important? Because if your patient is anuric, if the patient is not passing urine at all, this means that what you are doing is actually temporary. You are just pushing the potassium inside the cell. And after a while, a rebound will happen and the potassium will go up again. So in this case, if the patient is anuric, I'm expecting the potassium to shoot up later on after the effect of insulin dextrose and salbutamol goes. In this case, I should think about dialysis in such patient. But if the patient is passing urine, this will give you peace of mind because you can later on push the potassium outside the body through the urine. Does it make sense? Hello? Is it clear?
Yes.
Yeah, okay, excellent. In cases of chronic hyperkalemia, we can put patients on low potassium diet and consider calcium resonium or currently Lokelma, which is sodium zirconium, which are potassium binders, but this is actually for chronic cases only. It is not in the acute situation we face usually, because the action will start after 48 hours. So it doesn't suit emergency situations. Also, one of the important things is to stop any drug associated with hyperkalemia. Stop ACE inhibitor, ARPs, potassium-sparing diuretics like spironolactone, amiloride, eprednone. Okay, so this is a management of hyperkalemia, which is very important in this case. So Mr. Jones' venous blood gas sample showed a potassium of 7.7. Oh, it is higher than the morning. It was 6.9 in the morning. Following the calcium gluconate and the insulin dextrose, a repeat measurement shows that his potassium is now 5.9, so it is fine. It is moderate now, because you know mild hyperkalemia, so it's mild, between 5.5 to 5.9, moderate 6 to 6.4, and then 6.5 and above, it's severe. So we now succeeded to reduce the potassium down, good. His ECG changes have resolved now. That you have tackled the immediate urgent issue of his potassium, you are able to get some more history from the patient. So we can get some history of the patient. The history in the examination and investigations should aim to answer three main questions. So the patient coming to us with creatinine above 600, so he is in renal failure, okay? So the first question we need to ask ourselves is this is acute or chronic renal failure? Second, What does he have? Why does he have renal failure? Is it pre-renal, hypotension, hypovolemia? Is it renal due to intrinsic renal disease, or post-renal due to obstruction? What is the cause? And third question, does he have any symptoms as a result of his renal impairment? Is it symptomatic or asymptomatic? Okay. First of all, is it acute versus chronic? Okay. So why should we know if it is acute versus chronic? Yeah, there is very important issue. Acute, usually reversible. And so you can manage the patient, you can save the kidney, you can get the patient out of dialysis the rest of his life. But in case of chronic, chronic usually is progressive. If I know that the patient last year his creatinine was 300 and now it is 600, and the patient has chronic kidney disease, this means that we are going in the way of dialysis. I can't save the patient this fate. So acute is very important because it is a disease characterized by sudden onset and rapid deterioration in the kidney function, but usually it is reversible and I can save the patient. And if not managed well, it can cost the patient his life as well. So I want to ask you an important question. How do you know if this presentation is acute kidney injury or chronic?
You can see what their renal function has been like if they've had any recent blood tests.
Yes, this is good. If the patient had previous blood test, okay, in the last week, so this will be very clear actually. If the patient last week his creatinine was 70 and today it is 600, this means acute kidney injury. Or last week it was 300 and it was like this all over the last year, but now it's 600, it is acute on top of chronic. So the most important actually is returning back to the notes of the patient to know what was his baseline creatinine. Okay, so this is the first and important point. What else? What else can tell me?
Is he anemic?
If he's anemic, yes, it is good point, but it is not very sharp actually, because you may have a patient with acute kidney injury with anemia, like patients coming in pre-renal acute kidney injury due to hemorrhage or bleeding, or a lady who had postpartum hemorrhage. Okay, so sometimes anemia, yes, you are right. If the patient is chronically anemic, it may be chronic, but also some cases of acute kidney injury can present with anemia. So what else?
Symptoms as uremia.
So sorry, I couldn't hear you.
Symptoms as uremia.
Symptoms as uremia.
Yes.
But as you know, yes, it is more common in chronic cases. But
Confusion, hiccups, itching.
yeah, it's more common in chronic cases, if especially if the patient has it for a long time. But also it can happen in acute situation. But there is a very, very important point which can tell you if this is chronic or acute.
Has he got nocturia?
Nocturia, yes, it is also something which can indicate that, but don't forget that the patient may get lower urinary tract symptoms in cases of prostate or bladder problems.
As the patient
Ultrasound scan?
output.
Yes, what are you going to find in the ultrasound?
You got atrophy of cortex?
Yes, shrunken kidneys generally. If you have small sized shrunken kidneys, this indicates chronic situation, because the acute actually is of short time. So there is no time for the kidney to shrink. Okay. So they are the two things. Suspect chronic if small kidneys less than 9 centimeter on ultrasound. Of course, as you mentioned, anemia, low calcium, high phosphate, all are things which can support. Okay. But the only definite sign of chronic disease is previous blood results showing high creatinine and low eGFR. So this will be very clear. If you look at the previous blood tests and you find he had impaired kidney function all the time. This is chronic. Good. So let's return back to Mr. Jones. Okay. So 1 week before admission, he had these blood results. So sodium was 134, potassium was 4.9, chloride 96, urea 19.6, and creatinine 217. So his creatinine was actually higher before that. And so this patient has acute on top of chronic kidney disease. If we look at acute renal failure, okay, so we have three groups, three categories of causes of acute renal failure. They are pre-renal, renal, or parenchymal, or intrinsic, or post-renal. Okay. So if we look at the next figure, so if you look at the red lines, they are the blood vessels, and then the yellow are the ureters going to the bladder, and then the urethra. Okay. So we have three groups. Pre-renal means that the blood flow to the kidney is reduced. Okay. So why this reduction happens? You have many causes. Repeated vomiting and diarrhea. If patient gets gastroenteritis, it's common actually to find in old age. You find a patient who stays a few days at home with vomiting and diarrhea and coming now with acute kidney injury. This is pre-renal because dehydration is the cause of this acute kidney injury. Or patient coming in accident with blood loss and pre-renal. This is hypotension, decreased renal perfusion leading to acute kidney injury. Or post-operative bleeding or hypotension, or a lady in postpartum hemorrhage. Okay, so in this case, you find that all the pre-renal causes are not related to the kidney itself. They are related to hypoperfusion of the kidney due to decrease in the effective blood volume, like in case of fluid loss by diarrhea or vomiting or polyuria, or blood loss due to accidents or other causes. So this is pre-renal. Renal, if you look at the kidneys themselves, means that there is intrinsic renal disease. And this intrinsic renal disease may be glomerulonephritis, may be vasculitis, may be anti-GBM disease, may be tubulointerstitial nephritis. So anything affecting the kidney tissue itself, whatever, glomerular or tubular or interstitial, all these cause intrinsic kidney disease. And then if we look at the ureter, bladder, and the urethra, so after the formation of the urine, if there is obstruction, we call it obstructive or post-renal. So you may have obstruction of single ureter or bilateral obstruction of both ureters, like bilateral stones or retroperitoneal fibrosis, or in the bladder, if you have bladder mass affecting the trigone, so obliterating the orifices of both ureters, or the most common famous cause, benign prostatic hypertrophy or urethral stricture. So any obstruction in the way can close the way of urine, causing back pressure on the kidney and causing obstruction, or what we call post-renal. Okay, so they are the three groups which can cause acute kidney injury. And this is another slide showing the different causes, whatever pre-renal, renal, or post-renal. So how do we diagnose the acute kidney injury? So let me put in the display mode just for you to see it. So for acute kidney injury, we have three stages actually, and we have guidance for diagnosis called the KDIGO staging. KDIGO means kidney disease improving global outcome. So it is a group in America of nephrologists who put this classification. And actually, if we look at it, they used two simple criteria to diagnose acute kidney injury. a simple test, which is a creatinine, very cheap, available everywhere, and urine output criteria, which can be measured bedside, and it is very easy, not expensive, okay? So simply, if the patient's serum creatinine increases more than 26 micromole per liter within 48 hours, or it goes above 1.5 to double the reference serum creatinine or baseline creatinine in 1 week, we call it stage 1. 1.5 to double. Like what? Like the example I mentioned. If your patient's serum creatinine last week was 70 micromole per liter, and today the patient has come to you with serum creatinine 120. So if you calculate it 120 to 70, it is about between 1.5 to 2. Okay, 2 actually will be 140, double the reference range. So we consider this as a stage 1 AKI. If it is double to triple the reference range, we call it stage 2. If it's more than triple or threefolds, we consider it stage 3. So the same patient, if it is 120, it is a stage 1. If it is 190, it is a stage 2 because it is between 2 and 3. If it is above 210, it is stage 3 AKI. This is according to the creatinine. Of course, we have other criteria for stage 3, like if creatinine is more than 354, or if the patient needed renal replacement, the patient is in ITU in the filter or needed dialysis. Okay? Urine output criteria, if the patient passing less than half ml per kg per hour for 6 consecutive hours. So if this patient is 70 kilograms, this means that if the patient is passing less than 35 ml per hour for 6 hours, this means acute kidney injury stage 1. If the same figure, 35 ml per hour, but for prolonged time, 12 hours, it's stage 2. If it is less than 0.3 ml per kg per hour for 24 hours, or anuria. Anuria means that the patient is passing less than 50 mLs. Oliguria less than 400 ml per 24 hours. Anuria less than 50 ml per 24 hours. So we consider it as stage 3. So there are 2 criteria. So what is the baseline creatinine here? We consider it the last creatinine 7 days ago. But in reality, you will not every patient coming to you with a blood test 7 days ago. So in this case, you can consider the baseline creatinine is the lowest creatinine level in the last 3 months. Okay, in the last 3 months. So as a rule of thumb, at least 50% increase in creatinine that occurs within 7-day period, we consider it as acute kidney injury. So what are the risk factors for acute kidney injury? We have, you can see in front of you, some labeled in orange and others in green. So the labeled in orange, they are non-modifiable, like the age. You know, acute kidney injury happens more in old age due to the atherosclerosis of blood vessels, which affects the renal blood flow. Diabetics, patients with heart failure, hypertension, chronic kidney disease. It's very important. The most important risk factor to develop acute kidney injury is if the patient has chronic kidney disease. And there are some modifiable risk factors like hypovolemia. You can correct hypovolemia by fluids and drinking. Sepsis and infection, you can treat with antibiotics. Medications like S inhibitors, angiotensin receptor blockers, diuretics, spironolactone, trimethoprim. And for trimethoprim, actually, it doesn't cause acute kidney injury. It just interferes with the secretion of creatinine through the tubules without effect on the GFR. So let's look at the mechanism here, which will be interesting to us. So for the pre-renal, we have here, as you can see, the afferent arteriole, and then the glomerulus and the efferent arteriole. Okay. Number 1, as you can see, systemic hypotension. Systemic hypotension can happen due to volume loss, cardiogenic, or sepsis, exacerbated by vascular disease, if the patient has vascular disease, this may make him vulnerable to low perfusion. And non-steroidal, why non-steroidal anti-inflammatory can help in perirenal acute kidney injury? Because, you know, non-steroidals are antiprostaglandins, and the only prostaglandin, dilator prostaglandin in the kidney is prostacyclin. And when the non-steroidal inhibits it, it will cause vasoconstriction of the afferent arteriole, decreasing the renal blood flow. So can you imagine if you have a patient who has diarrhea or vomiting, losing blood, old age, atherosclerotic, and also taking ibuprofen or non-steroidal? So all these factors altogether will lead to acute kidney injury. There are some factors can affect the efferent arteriole, like the ACE inhibitors or ARPs. Oh, it's very strange. So why ACE inhibitors and ARPs can cause this type of acute kidney injury? Because, as you can see, in the efferent arteriole, usually if the body is in a state of shock, this will decrease the flow through the afferent arteriole. Reflexly, the renin-angiotensin system will stimulate the formation of angiotensin II, which will act preferentially on the efferent arteriole, causing vasoconstriction. This will keep the blood inside the glomerulus. If you relax the efferent arteriole and open the drain, this will lead to decrease in the GFR. This is what the ACE inhibitors and ARPs do. And so, if you have a patient, you put him on ACE inhibitors or ARPs, tell them that if the patient gets diarrhea or vomiting, he can stop it until diarrhea and vomiting subsides and return back to it to avoid this effect. So the next slide, I know you are not seeing it now, but I will keep it until you answer my question. So can you mention to me 3 simple bedside methods to differentiate the causes of AKI? Now we have 3 groups of causes. We have perirenal, we have renal, we have postrenal, okay? So can you tell me how can you differentiate between pre-renal, renal, and post-renal bedsides by doing simple methods?
You could do a bladder scan, see if they're obstructed.
Excellent. Bladder scan can rule out obstruction for me. Excellent. This is very good. And of course, ultrasound can follow as well, because if the obstruction is higher at the level of the ureters, the bladder may be empty. But good. Imaging, bedside imaging can help to rule out the obstruction. Good. We have another 2.
JVP, lying standing blood pressure.
Excellent. GVB, lying and standing. It will diagnose what? Which category?
Hypovolemia.
Hypovolemia, yes, pre-renal. So I can diagnose pre-renal by checking the blood pressure, lying and standing. Excellent. The last one.
Urine dip.
Yes, excellent. Urine dip. If I find the blood and the protein in the urine, this indicates intrinsic renal disease, maybe glomerulonephritis, maybe vasculitis. Okay, so I will choose a slide now. So lying and standing blood pressure pre-renal, urine dip renal, and ultrasound QP post-renal. Okay. So now I think we answered the first 2 questions. First question, is this kidney failure is acute or chronic? And we said in this case it is acute on top of chronic. Okay. Second, what is the cause of this renal failure? Of course, we'll see the rest of the scenario of Mr. Jones, but we know now that we have pre-renal, renal, and post-renal. Third question we should answer, does he have any symptoms associated with complications of renal failure, like symptomatic uremia, nausea, loss of appetite, symptoms associated with uremic pericarditis, uremic pruritus, itching, uremic encephalopathy? Acidosis, patients may hyperventilate in an attempt to lose the carbon dioxide to compensate for metabolic acidosis. You find the patient short of breath. So shortness of breath in such patients may be due to fluid overload, volume overload, or due to the acidosis. Anemia, is the patient complicated with anemia or not? Hyperphosphatemia. So is there complications or not which I should manage? Okay. So the kidney actually is seriously ill. So what features of the examination might indicate that Mr. Jones needs urgent dialysis? So, you know, we send the people for dialysis if the patients have pulmonary edema, not responding to medical management. What I mean, not responding to furosemide, okay? So, and here I want to ask you, can you give furosemide to patients with acute kidney injury or not? Hello?
Yes, we can give furosemide.
When?
If somebody got a compensated heart failure, then you can justify that with giving furosemide and get the heart function better, and then can supply the heart blood to the kidneys.
So what about other patients with acute kidney injury without heart failure?
So is that furosemide just for fluid overload or?
Yes, that's right. Of course, I agree with you about the heart failure patients because this is a main point in management. But for other patients, furosemide is contraindicated, and you should stop it if the patient is dehydrated. Okay, of course, because all your aim here is to rehydrate your patient. Okay, but if your patient is overhydrated or impending pulmonary edema, yes, in this case, you have the right to use furosemide to offload him. Okay, so furosemide can be used, but in case of fluid overload, and actually one of the diseases in which there is fluid overload is heart failure, as you know. Pulmonary edema not responding to furosemide, severe acidosis not responding to IV bicarb, hyperkalemia refractory to treatment, and symptomatic uremia. Okay. So on examination, Mr. Jones clinically avolemic, pulse 90 beats per minute, blood pressure 160/90. On auscultation, there is no pericardial rub, but he does have bipasal crackles posteriorly. On examination of his abdomen, his bladder is palpable at 2 centimeters below the umbilicus. Rectal examination reveals small, significantly enlarged prostate. He has mild peripheral edema in his ankles. So admission bloods showed potassium 7.7, urea 34, creatinine 7.29, so it's going up further. He was not anemic, hemoglobin was 12.7. So what do you think the patient needs now in the light of this description?
A catheter.
Yeah, but before the catheter, he needs ultrasound. Okay? Yes, of course, I agree with you. He is obstructed. So the ultrasound here shows a kidney of normal size, 10 to 12, with some preservation of corticomedullary differentiation, which is good, but gross hydronephrosis, as you can see, the kidney is hydronephrotic and the hydroureter, and as you can see, the bladder in the picture to the right is quite distended, and clinically it is 2 centimeters below the umbilicus. So the patient, if we ask what you would do next, so the patient will need urinary catheter and urology input as well, and to repeat the unis. My question, next question to you here, okay? So what is the main problem which can develop following resolution of obstruction by insertion of urinary catheter?
Post-obstructive diuresis.
Yes, excellent. Post-obstructive diuresis. This is very important. What is the risk of post-obstructive diuresis?
The patient becomes dehydrated because they're diuresing excessively.
Yes, the patient can become dehydrated, and we go to another type of renal failure, which is perirenal. Okay, this is one point. Second point, the patient may go into severe fluid and electrolyte imbalance because if he loses a lot of electrolytes like sodium and potassium, so we should keep an eye actually in this stage. So following treatment of urinary obstruction by insertion of catheter, patients frequently become polyuric due to temporary tubular dysfunction. So in the 8 hours following catheterization, Mr. Jones passed 6 liters of urine, and unless he is placed on an adequate fluid replacement regime, he will be at risk of developing pre-renal failure due to intravascular volume depletion. So generally, the acute renal failure management, you should define what's the diagnosis. And if the patient is dehydrated, you will give intravenous fluids, but of course, this intravenous fluids should be monitored, especially if the patient is oliguric or anuric, to avoid flooding the patient with fluids, stop nephrotoxic medications, and exclude obstruction. If the patient is obstructed, he needs to relieve the obstruction. If the patient has nothing to say, he is pre-renal and no obstruction, and the dipstick shows blood and the protein, so mostly the patient has intrinsic renal disease and he may need a biopsy. I will stop here. Okay, I think we covered the acute kidney injury, and in another occasion we can cover the chronic renal failure. I think we have about 4 minutes for questions. I want to apologize that I prepared another software which would make it more interactive with certain types of questions, but unfortunately it didn't work. I hope it works next time. So any questions, please? Hello? Okay, I think you don't have any questions. So I will leave my place to Anita now, if she wants to tell you anything.
Thank you very much.
Okay, you are welcome. Okay, thank you all, and hope to see you in another lecture. Thank you.